I have no financial interest in the content of this video. Eye syndrome comprises a spectrum of three clinical entities: progressive essential iris atrophy, Coogan-Rees syndrome, and Chandler syndrome. We present to you a 61-year-old female with gradual painless loss of vision in the left eye for the past 1 year. She was diagnosed as eye syndrome with secondary glaucoma. On examination, she had multiple patches of iris atrophy, correctopia, peripheral anterior with a raised IOP. She was prescribed anti-glaucoma medication. Subsequently, she underwent cataract surgery with Amath glaucoma valve implantation. However, she redeveloped synechia requiring anti-glaucoma medication with gradual decline in vision. Specular microscopy or affected eye demonstrated the presence of the typical ICE cells, which are abnormal epithelial-like endothelium. We planned for a Descemet stripping endothelial keratoplasty and synechiolisis of the affected eye under local anesthesia. The lenticle was manually prepared using an artificial anterior chamber, 400 micron guarded knife, a pair of short and long lamellar dissectors. Central 8 mm of the post-corneal epithelium was debrided for better visibility. The periphery was avoided. Area of the Descemet membrane stripping was marked. Side ports were made for instruments and for placing the anterior chamber maintainer. A 360-degree synechiolisis was attempted using iris spatula under artificial and anterior chamber maintainer. Trypan blue staining of the Descemet membrane was done, followed by scoring of the Descemet membrane using reverse Sinskey hooks. Peeling of the proliferative membrane was done. Using micro forceps. A 5 mm limbal wound was constructed. The proliferative membrane was removed using a micro forceps. The desmetorexis was completed along with release of synechia. The projected iris stacks were excised using micro forceps and micro scissors were used to cut the projected iris stacks. This was put for better visualization. This is the release of the synechia. With the micro scissors, the iris stacks were cut flush with the iris. Further vitrectomy cutter was used to complete the excision of these projected iris stacks. The sheet slide was placed over the iris. Donor cornea was punched using a 7.75 millimeter trephine and then placed over the sheet slide with endothelial side down over cohesive viscoelastic substance. The lenticle was separated from the cap and pushed over the sheet slide. The sheet slide was removed and wound was sutured with 10-0 nylon sutures. The lenticle was centered and secured to the donor cornea to the host bed by injecting a full chamber air bubble. Finally, the side ports were sutured. Postoperatively at 4 months, the cornea cleared up well. Vision improved to 20/50 and AIOC showed a well-attached lenticle, showcasing a successful descent. A few tips to remember are the pivotal role of artificial chamber maintainer, which maintains the anterior chamber, and a 360-degree synecholysis. Using microforceps and microcisors for removal of the proliferative membrane and the projected iris tags, and attaining a full chamber airfill before the lenticle insertion to ensure there are no more synechiae. It's important to avoid injury to the existing plebeian tube. So endothelial keratoplasty offers advantages of faster and superior visual rehabilitation along with better preservation of the corneal architecture. There's always an ongoing debate among the corneal surgeons whether full thickness keratoplasty or endothelial keratoplasty should be performed in such scenarios. Endothelial keratoplasty, if done precisely, can prevent the downsides of an open sky procedure, that is penetrating keratoplasty.